talk about understanding rehospitalizations and avoiding preventable rehospitalizations. Before we get started into that, definitely want to kick off to see where we're at with the current public health emergency transitions. Right now, we have the up-to-date status in South Carolina for report on NHSN is 48%. So we did grow a little bit and hoping to see that moving forward. We do recognize that CMS and the White House would like to see us encouraged to grow up into the 75th percentile. So there's some opportunity for us, but I think as we look ahead, we just need to ensure that we're running our systems. We have a process in place for identifying, tracking, and monitoring the vaccination needs of our residents and our families and staff members, and offering those on a routine basis. Looks like we continue to come down off our peak in January from COVID cases. And the week ending 3/12, we had 76 positive case counts across the state for South Carolina, and that led to a COVID rate of 4.7. Looking at our map, it's beautiful to see South Carolina all in green for the community levels. This is where we see low levels of community rate across the state. But when we look at the transmission levels, which is where we as operators should be looking at how we are applying our policies and how we're looking at our standards for basic infection control mitigation strategies, we still see some areas of opportunity within South Carolina. The pink color, I guess, is high levels. Then that orange salmon color is substantial levels, and yellow is moderate, with blue being low. So we do have a couple of low areas for transmission rates, but with the high levels still out there, we want to maintain that high level of focus and keeping with prevention strategies, mitigating that potential spread, increasing our cleaning protocols, just to ensure that we are doing everything we can to maintain or prevent having outbreak spreads within our organizations. Regardless of what happens with the public health emergency, the standards of practice are now part of what we look at in from infection control and CDC recommendations. So we should be looking at our policies and treating this like we would treat cases of influenza, cases of norovirus that we have out in the communities, actions that we take to mitigate the impact on our communities, our residents, and our staff. We are going to be talking a little bit more about that next week as we into our presentation with Julia Brooks and myself, digging into how we continue to apply mitigation strategies and infection control guidelines coming through the public health emergency. Okay, without further ado, I'm very excited to hear Julia Brooks speak on rehospitalizations. Julia comes to us with a wealth of knowledge and experience. And if you were lucky enough to join us for our last session, it's amazing information and really thought-provoking. So Julia, I'll turn it over to you. Looking forward to learning more about rehospitalizations today.
Good morning, everybody. Can you hear me okay, Alyssa? Okay. All right. We're going to talk about rehospitalizations from a little bit different perspective. I called this presentation ER transfers. And the reason I call it that, and the reason I think of it that way, is because once patients and residents leave the facility, we don't have any control over whether they'll be admitted to the hospital or not. And those of you who are in leadership positions know that. Once they go out your doors, you don't know what's going to happen. It depends upon the situation when they get to the other side. So our goal should be to try, if possible, and it's safe, to keep the patients and residents in the facility, keep them from leaving the doors. So the first thing we always want to think about is my center where I need it to be? And how do you really find that out? This is a mindset process. And the reason it's where you need it to be is because you need to as a leader, wrap your head around the idea that it might often be better not to send people to the hospital. We all know that operationally, we don't always send people to the hospital for the right reasons. And we need to consider that, because what they're going to encounter on the other side when they leave your doors might be worse for everybody concerned. So how do we find out where our centers are? Next slide. Thank you. We can look at logs. We should be keeping logs of everybody going out, and directors of nursing or their whoever is backing them up should be directly involved in every possible transfer out when it's first being looked at, and log that information. Your MDS nurses can tell you when they're getting ready to code something and how they're going to code it, and also your MDS reports, as well as your QAPI reports and reports from organizations such as CCME and HIQN. Those are important reports that you can look at. So you have a lot of data and a lot of information to look at. And feedback from your families. What are your families telling you? Do they have confidence in your care? What are your providers telling you? And I'm talking about now your internal providers, your medical director and his or her other providers. Usually there are several. Do they feel that you all have the monitoring capability to keep an eye on someone in your center to avoid a transfer out? And other facility leaders, is the administrator on board? Are they confident in the nursing care in your building? That's important to find out. And if not, why not? What are the family's questions? What are the family's concerns? And we'll talk about in a minute how to better discern that and how to better help your families walk through these issues too. Also, the transferring hospitals. What's going to be said when they arrive at the ER? What's said when they leave the hospital? Do they talk up your facility? Do they talk up the care? People really look at that. They really do. And then last but not least, certainly, are the patients and residents. Are they confident in the care? Are they seeing big gaps in staffing? Are they concerned about things that are said or not said? Are they concerned about things that they know should be done for them that aren't being done? Night shift never takes the vitals, or night shift never brings the water around, or whatever it is. Are they seeing things that concern them overall about and erode their confidence in your ability to provide the care in the facility if they have an acute situation? Next slide. Okay, so some other resources that you can look at in addition to a lot of reports. Your Interact is a great resource, and this is not a public service announcement for Interact, and yet it is, because that is the best resource. It's one I used daily and relied upon heavily when I was a director of nursing. And anecdotes about this are for another time, because we're going to do more more in services on rehospitalization, but Interact was really what I credit my ability to have my rehospitalization rate at 3%. And that was a number of years ago, about probably 10 or 12 years ago, in a high acuity facility. But we're going to talk more about that and why I think I was able to have that rate at another date. But I definitely use the Interact tools, pretty much all of them. Your relationship with your lab, that's really important. And we're going to talk about some specifics in a few minutes. The obvious one is going to be blood cultures. Can they do blood cultures for you? Are they getting you timely information? Who is your backup if the lab can't come in? They come in a lot of times once a day, somewhere between 4 a.m. and 6 a.m. If a patient or resident starts declining later in the day or has some changes in signs and symptoms, can you do labs and get prompt results? Because that's going to be important, and we'll find out why more in a minute. Your medical record reports, and by that I mean reviewing your electronic charting, tracking and trending, looking at your graphs, looking overall at things. making sure that you are keeping track daily with your infection control program. That's going to be key. And we'll see why in a minute. And your daily huddles. What's going on? If someone who's usually got a baseline of minor confusion, suddenly is much more agitated or has a decline in their confusion or a decline in their mental status, that can be significant. That can, and you can hear that often in your daily huddles. Next slide. Okay. So what can you do? You've got all these resources and you've got all this data that you can look at. What can you do? Well, I'm going to suggest that you need to consider a 360 approach. This can be applied to a lot of things, but today we're going to talk about it in terms of rehospitalizations and transfers out. I mentioned earlier Interact. There's a new, fairly new tool in Interact called the Decision Guide, and that is something you can use with your patients and families. I'm not going to go into it specifically. There was recently a presentation on it. And you can also find the information on it on the Interact website. But the decision guide, the reason I call that part of the 360 approach is that is from really pre-admission, at admission, and it carries through all the way through the admission process and the patient's stay in your center. Have education in place. Have your supplies in place. By supplies, make sure that your blood culture tubes are not outdated. That's a very important aspect. Make sure that you've got your IV fluids in place that you can use if you need to. And look at your relationships with your hospitals, your labs. Are your hospitals able to accommodate you? Are you sending somebody to the ER because you want a scan? And ER patients get priorities on the scans most of the time, except for ICU patients. Maybe you can schedule a scan without them going to the ER. I would think that nowadays the hospital would probably welcome that opportunity given the status in the ERs. And also your labs. Again, we talked about that before. What is your lab process? What is your backup lab process? A lot of facilities use a runner or a courier to be able to draw labs in off hours and send them to a hospital. So look at that process. And portable radiology, that can be key for Doppler studies and some x-rays, those kind of things. Those things that I just mentioned here should all be contracted. So hold them accountable for what their contract tells you that they should do. That's really important so that you can provide consistent care to your patients and residents. Work closely with your medical director. They have to be on board. Most understand the importance of it now, particularly if they're members of and certified. I don't know if AMDA does a certification, but I know that AMDA does a lot of information and gives a lot of information to medical directors on rehospitalizations, and work closely with their providers. And we'll talk more about that in just a minute. Address unrealistic goals ASAP. And by unrealistic goals, I'm really talking about what your patients and residents want for their stay and what the families expect out of the stay. If their goal is to go home and go to a wedding and attend several grandchildren's birthdays, and yet they can't get out of bed, their heart failure is worsening, none of the medications are helping, and they tell you, nobody told me this in the hospital. They told me I could get well. Find that out. Find that out. Sometimes you have to pull social services records, which often aren't sent with admissions, but it's worth finding out and address these goals. The decision guide will also help you address these goals and gives the patients and families a means of addressing these goals and really looking at them themselves too. So a lot of these are done outside of the facility, and a lot of these are done prior to admission to the facility. So that's why I call it a 360 approach. Next slide. We're going to change the topic a little bit. When I reviewed some of the data that Alyssa shared with me, sepsis was a big reason for transfers out. Sepsis is a significant reason for transfers out. But my question is it really? Is it really sepsis? I mean, it can show up on a report and we can call it that, but how many of your patients truly had sepsis when they got to the hospital? That's something to think about. Regardless of that, UTIs was also a frequent reason. We know they can lead into sepsis fairly easily, very easily in the elderly population. And one of the most high reasons, the highest reason for sepsis, other than wounds, wound infections. And so again, it seems to always go back to infection control, doesn't it? One way or another. So we will talk a little bit more about that. All right, next slide. Okay, as I said, the main etiologies that we see related to sepsis and in general related to transfers out are UTIs. C. diff is also popping up a lot, but it's a distant second to the UTIs. So how do we avoid them? How do we avoid UTIs? Hydration is one way. So that gets us into what? That gets us into our other programs and systems and making sure that they're in place. Next. Okay, again, is it really sepsis? Sepsis is definitely serious. It's relatively easy to report. It gets attention from the ERs and the hospitals, doesn't it? And it warrants acute care. But if it's not really sepsis, maybe they didn't really need to go out. Or maybe it was very early sepsis, and with prompt action, you could have turned it around. So how do you treat sepsis and how do you assess sepsis? The number one way, to avoid it. Absolutely avoid it. So again, being proactive, and we'll talk more about that in future slides. So let's go to the next slides. This is per CDC guidelines, which I thought were interesting, and you can certainly go on that site and look up more ways to avoid sepsis. Prevent infections, obviously, any kinds of infections. The number one way in all settings was to prevent infections. And many of you hear this from us all the time, is hand washing. Hand washing, hand washing. Hand washing is never going to go away. It's always going to be really important for a lot of aspects of care. Vaccinations are also key. And they are going to continue to be more and more important. So a better understanding of vaccinations, how they work, what they're for, and how they help us is an ongoing education issue that we're going to need to address with staff, residents, and their families. And then the third thing is staff and patient resident hygiene, adequate cleaning after incontinence, overall staff hygiene and resident hygiene, a little bit beyond hand washing we're talking about. Now, let's think about some early signs of infection and some potential early signs of sepsis. This is from the Interact tool. We're going to talk for a second about the 3-100s. We're going to get into some math and some numbers now going forward. Temp above 100, heart rate above 100, systolic blood pressure less than 100. So it doesn't have to be all three of these things. It can be any one of these things. And obviously, a lot of folks have a systolic blood pressure less than 100 all the time. So you have to trend it against what their baseline is. But these are things that should get your attention, that CNA should report promptly, and they are the reason that your vital signs programs need to be in place. Next slide. Okay, we're going to talk about something else that I thought was really interesting and would not have really thought about. We're going to check out the map. And by map, I'm talking about mean arterial pressure. And you're like, whoa, I did that in the ICU. And I thought the same thing at first. But let's talk about what we can do and how we can assess mean arterial pressure in the nursing home. get into that though, again, as I said, you're thinking mean arterial pressure. We're going to deal with that in the nursing home. There are ways to do it. We'll talk about it in a minute. So think about your own mindset as I'm bringing these things up. My background, the first half of my nursing career was in critical care. So yes, I dealt with mean arterial pressures a lot. They were very detailed. We had invasive ways of obtaining them. So you're wondering what I'm going to get to. But there's a simple formula we can use with blood pressures. And also, I did some research this morning. A vast majority of the electronic machines calculate mean arterial pressure. It's just not something that we address. So think about how that made you, what that made you think. And do you maybe need to work on your mindset a little bit about trying new ways to keep patients in the facility? Next slide.
Julia, I think that we're coming to the end of the slides.
Oh, no, I had a couple more. Let me, all right. Okay, well, we're going to talk about mean arterial pressure. That's weird, Alyssa. I don't know what happened to the other slides. But we'll talk about mean arterial pressure for a minute. And we're going to do some math. So you can put your answers into the chat. As I said, you can determine mean arterial pressure by looking at the histories in your electronic blood pressure machines. And I suggest you do that. If someone complains of a little abdominal pain, has urinary frequency, has some kind of change in mental status, see if that mean arterial pressure might be dropping. The goal for a normal mean arterial pressure is to keep it at or greater than 65 millimeters of mercury. And we're going to do some math, and I'll tell you the formula first. The formula we're going to use is the diastolic blood pressure doubled, added to the systolic blood pressure, and then we're going to divide that number by 3. So I'll walk you through it. The first blood pressure I'm going to give you is 140/70. So your systolic is 140 and your diastolic is 70. So multiply your diastolic, which is 70, by 2, and you have 140. And then we're going to add 140. I actually did this wrong, but I did my calculation wrong. But we're going to add 140. And so we get 280, and then divide 280 by 3. I get around 93. Is that what everybody got? Very good. 93.3, Deneen. Great. So that's above our goal, isn't it? So the next problem I'm going to give you is a blood pressure of 110/60. So take 60 and multiply it times 2. Add that to 110 and divide by 3. Anybody put an answer in the chat yet?
Looks like Deneen's on top of it. She put in 70.
Got it. I see it. There it is. Yeah. Good, good, good. So we're still okay. Very good, Wanda. Thank you. We're still okay, aren't we? We're above 65. Let's presume that this is the same patient that we're talking about. Now we've seen a drop. We've gone from 140/70 to 110/60. Next problem, 100/60. Multiply your diastolic times 2, add it to the systolic, and divide that total number by 3. Okay, mean arterial pressure is 76. So we're still not really trending there. And then the last one I'm going to give you is 90/40. Anybody?
Here comes Wanda, 56.
There's Wanda. Wanda's got it. Okay. All right. So obviously from 140/70 to 90/40, it doesn't take a lot to see that we've had a big drop there. But now our mean arterial pressure has fallen below 65, hasn't it? Significant below 65. So if you pull the history on your Rosies, a lot of them are called Rosies, your electronic blood pressure machines, you can look at that mean arterial pressure and see if you've got a trend now, which I thought was very interesting. That can be a sign of early sepsis. They're considered adequate. It's considered an indicator of tissue perfusion, and sepsis can lead to shock. So if your mean arterial pressure is dropping, you're heading towards shock if you're not already there. Now, obviously, if you're in septic shock, you're going to be in the emergency room and you're going to be receiving care. Another value that involves the lab is looking at the serum lactate. You want to keep the serum lactate less than 2 milliosmoles per liter, or less than 18 milligrams. So you want to look at your serum lactate and see what's happening with that. And that's a possibility that your lab can do for you. I don't know how long serum lactates take to run, so that's something to find out. But the mean arterial pressure, I thought, was really an interesting way to let you know where this patient might be going. If you think you're going to keep the patient or resident in the facility, you've got to give fluids right away. You've got to draw blood cultures right away. They can't wait till the next morning when the lab comes in. And you need to start antimicrobials, either gram-negative, gram-positive, or anaerobic antibiotics, depending upon what the likelihood is of the infection at that point. That needs to be done within an hour of the recognition of sepsis if the patient has elected to be treated in your facility, which occasionally they will. The goal of care and the prognosis needs to be discussed with the families. And you need to be ready to present these. If you're going to give your families and your residents a choice, you need to be ready to accommodate them. Let's see, we reviewed the 100, 100, 100 criteria: temperature above 100, heart rate above 100, blood pressure below 100. All patients and residents with a suspected or confirmed infection and possible sepsis need to be considered for transfer unless they are placed on a comfort or a palliative care plan, or they're on hospice. If the patient or decision maker wants the condition treated but not in the acute hospital and understands the risk, the facility has the capability, needs to have the capability of managing the sepsis according to the interventions we just talked about. Fluids right away, blood cultures right away, being able to monitor MAP non-invasively, of course, and being able to look at serum lactates. There are algorithms for the management of sepsis in SNFs, and there may be more coming about that, but as present, they're not consistent with each other. And all this material I gave you about MAP and serum lactate have to do with, came directly from the Interact program. Serum lactate level over 4 is associated with a 27% mortality rate, just to give you a ballpark idea of what you might be looking at. And that's an important indicator of their prognosis in sepsis. So something to think about. I'm not sure what happened to the rest of my slides. That's okay. We'll just muddle on, and it's not, we're almost to the end anyway. I do want to say for the third time that you really have to have your own mindset about what is best for your patients. Obviously, we look at a lot of things. Some of the factors that I think should be considered, we talked about earlier about 3-100s, and we've talked about some other algorithms today. I did want to mention the 3 C's. You want to think about, obviously, a factor and a variable in sending people to the hospital is cost. Certainly cost to you, cost to the hospital, cost to the resident. And we want to also think about comfort. Hang on 1 second. Let me look at the note here since I don't have the slides up. And the last thing we want to think about, unfortunately, I think comfort should be the first thing. Cost should be a factor. It has to be nowadays for all the parties involved, and the convenience. Transfers take time. Unnecessary transfers could pull away services from someone else that needs them. It's unpleasant to go to the emergency rooms. If any of you work in the emergency rooms or have worked in them recently or have been to them recently, they're not pleasant places to be. And obviously the comfort. Make your facilities a place that your patients and residents are going to want to stay in, because this can be a factor sometimes. So we've talked a lot about sepsis being the big reason why we're sending a lot of folks out in South Carolina. So really evaluate, is it sepsis? And take it from there and utilize that decision guide from Interact, because that really helps your families to be able to deal with you and to work with you as well as your patients on trying to stay in the facility. Think about some other reasons. Your patients may not get food, they may not get hydration in the ER while they wait. Interesting anecdote, I could tell anecdotes all day, but one interesting one, patient was sent out for a falls evaluation when it was possible to have x-rayed him in the facility because there was not an evident fracture. It was just a possible fracture. And so he was sent to the emergency room instead, and he fell and fractured his hip in the emergency room. He did not have a fracture when he came into the emergency room, so he could have stayed in the facility. But shortly after he arrived to the emergency room, he was confused, he was anxious, he heard noises, and no one was with him. And he got up and he promptly fell and broke his hip. So another reason sometimes that we want to avoid sending our folks out. We can take a situation that we maybe could have handled and we can make it much worse. So we can talk more about that in another day, but I think that's significant. And going back to the title of my presentation today, avoiding transfers to the emergency room. Again, I want to reiterate, once they leave your doors, you have no control over what might take place or whether or not they're going to be admitted. And we all know that. We don't want our patients away from us unnecessarily if we can avoid it. It interrupts their care. It interrupts their rehab if they're in your facility for rehab. And it ultimately causes them a lot more stress and anxiety. One last thing I did not have a slide on that I wanted to touch on in terms of infection, though, is immune senescence. Immune senescence is the process that occurs with biological aging. Old age or geriatric patients have immune senescence, and it is the inability of the body to fight infection as it once did. The body can and does fight a small amount of bacteria, And by the way, sepsis can also come from COVID and other viral illnesses as well, but primarily it's caused by bacterial infections. Immune senescence is affected by sleep deprivation. gut dysbiosis. So including some probiotics in your facility can help your patients fight off infections better. Dysregulated immune cells. In other words, the immune cells don't work as well as they used to. The phagocytes are weaker and they don't work as well. Chronic viral infections such as CMV or HIV, obesity, stress, all these things impact and intercede with old age and cause the development of immune senescence. The immune cells don't function as well. There's reduced vaccine efficacy. So even though they receive the vaccines may not be as effective. And there's chronic low-grade inflammation that the patients have that also make them prone to infections. So these are things that you need to think about and educate your families and patients on along the way. As always, educate your staff, your CNAs, over notifying you and the staff of any signs and symptoms of infection, and remind them periodically through education what those signs and symptoms are. Timely vital signs are important, as we see, and explore those mean arterial pressures a little bit. That was kind of new to me. I don't think I ever really addressed those when I was a director of nursing in a nursing home. So it's something you can do non-invasively. And again, it may not be as accurate as what would be obtained in an emergency room or an ICU in a critical care situation, but it is something that you can track and trend that would give you an early warning or tell you if the patient is at risk for sepsis or not. Always prompt treatment and diagnosis of infections is important, but the best way is to prevent them in the first place, and then you will avoid sepsis. Thank you. That's all I've got, Alyssa. Thank you.
Julia, it's always so interesting to hear you speak, and I've learned so much. Not being a nurse, you make it easy to understand some of these very complex issues. Thank you for that. Want to open it up for our attendees. Does anyone have any questions? Feel free to unmute yourself or type them in the chat box. Would love to hear your thoughts. Looks Deneen is saying very interesting. Thank you, Julia.
Thank you, Deneen.
Julia, I had a question for you while we're people are getting their ideas or thoughts together. And this is, again, very simplistic from reader perspective in the non-clinician setting. Do you find it beneficial to, when we talk about hydration or the use of probiotics even, I'm not even sure how probiotics work, if we had a program in activities where we would include hydration through our activity program, or even yogurt parfaits or yogurt in different activities, would that help in the process?
Definitely. And you don't have to do true probiotics, although I see them frequently now. Some medical directors will do them. Just plain old yogurt. It doesn't have to be the Jamie Lee Curtis yogurt, but just plain yogurt. Yogurt parfaits are good. I've worked with activities settings before to do that. And what that does is it puts the good bacteria into the gut. I learned through some of my own experience as a patient how the gut is really the primary organ in the immune process. And so keeping that gut healthy and not letting the bad bacteria accumulate as any more than necessary is just overall good to the immune process. And because patients' blood cells are already not as functional, they're not as plentiful, and they don't work as well, anything else that we can do to counteract that immune senescence would be helpful. And always here in the Deep South, most of us, I'm sure, have activities programs already that include some kind of fluids, whether it's popsicles or something. The other day I was doing a site visit and it was margarita day. And so they had all kinds of interesting looking drinks that they were giving people. So whatever reason, however you can associate it with fluids, definitely helps.
That's great. And even when we look at the public health emergency and the guidance that we have, we can still socially distance, still be able to consume fluids and food in a safe manner, even when we have disease conditions or outbreaks that are happening in the surrounding community. So that's good to know to get back into that habit. It's been a couple of years since we were doing a lot of these things, to rethink about how we can introduce them back into our programs.
Hydration carts are fun. I've seen those used in facilities and had them in some of my own facilities too. They have like awning tops, striped awning tops, and they're fun looking. And then they just got a big cooler in them. And activities can take those around. You want to be careful because, again, infection control, and you've got to make sure those coolers have, you've got to have processes in place to clean those coolers and everything. But they attracted attention because they were on the rollers with big awnings over them. And for different holidays, they, would hang things off the awnings and stuff and make it fun. And that helps your CNAs too during their busier times. Activities can do that for you. And that's an awesome way to help provide extra hydration.
Wonderful. Thank you. Does anybody else have any thoughts, ideas, or best practices that they have in their centers that they want to share on ER transitions or QAPI programs? Anything that you have that you'd like to add? Well, while we're thinking about it, feel free to jump on in and chat in the box. I did want to share some additional resources that we do have out on the HCLIN site, not taking away from the amazing resources that Julia's talked about already with Interact and the decision-making guide that's on the Interact website. These are wonderful tools to utilize and bring back out into operations, see how what the best practices or how they might complement your center policies. We also have the emergency room department visit toolkit that is available on the HCLIN website. This helps us in doing a deep dive into emergency department visits and looking to see what may be causes for this, and helping with analyzing and then working on a solution for how to improve those outcomes. Because as Julia shared with us, there are times when we can avoid going to the emergency room or going to the hospital. We definitely want to do that. We want to be able to treat people in the community before it gets to advances to a worser state than it needs to be, or that we can avoid some preventable experiences that may not be good for our residents. The gentleman with the broken hip is just heartbreaking to think about. So we want to avoid that whenever possible. Additionally, we have the Stop and Watch. This is the ideas that work on the HCLIN website. Stop and Watch is a part of Interact. It is part of the communication flow that we have between all levels of individuals within our organization to identify changes in condition and allow us to analyze what may be happening and implement an intervention before that progresses forward. So there's definitely another plan how we can incorporate the Interact Stop and Watch program within our operations, as well as the tool of Circle Back. And this is when we're able to pull back around with our staff on care coordination ideas or changes in condition and what our interventions can be to avoid that hospitalization. Our next session is next week. Julia will be joining us again and presenting on infection control mitigation strategies. This is really important as we work through the public health emergency. We are still going to be responsible for ongoing infection control and containment practices, even though the public health emergency has ended. And the directives that we may have become accustomed to over the last 3 years start to come back into best practices. So as operators and as providers, we are now moving back into the pre-COVID realm of looking at best practices, using our analyzing and evaluation skills to be able to determine what our strategies are going to be to prevent unnecessary events from occurring and promoting the quality of life for our residents and our staff. So as we're transitioning the mindset, it's helpful to be able to look at some of these programs and processes in that new frame of light of how are we going to get back into this process of analyzing the needs and implementing those strategies. So we're very grateful to have Julia joining us and presenting into that information as we continue to move forward into the post-COVID operations realm. We will also be sending out new and updated sessions. As we talked about 2 weeks ago, we will be moving into a twice a month period. That's going to, because we're coming from transitioning through that COVID pandemic response, we're going to come into that twice a month meetings and bring these important quality topics to conversation into the discussion table. So stay tuned for that link. Feel free to accept it for the year, even if you're not able to make it on a couple of those sessions. That way it just logs in on your calendar. Would like to open it up if anyone has any questions, and if not, we do thank you for joining us today. I'll give you a few minutes back to your day and hope that you have an amazing afternoon. Thank you, everybody, for joining us. Thank you, Wanda. Always a pleasure to have you.
Thanks, Wanda.